Good morning, Dr. Williams. I wanted to discuss a challenging case I am currently handling, a patient with resistant hypertension. I've tried several medications, but their blood pressure remains stubbornly high. I'm not sure what else to do.
Good morning, Dr. Johnson. Persistent hypertension can indeed be a complex issue to manage. Let's review the patient's history and current treatment plan. Maybe we can identify any potential gaps or alternative approaches.
The patient is a 55-year-old male with a long-standing history of hypertension. He has been compliant with his medication regimen, including a diuretic, calcium channel blocker, and ACE inhibitor. Despite this, his blood pressure readings consistently show systolic values above 160 mm mercury and diastolic values above 100 mm mercury.
That's quite concerning. It seems like we've exhausted the standard treatment options. Persistent hypertension is defined as having either a blood pressure of 130, 80 mm mercury or more, despite maximally tolerated doses of 3 or more antihypertensive drugs with at least isang diuretic, or controlled hypertension with 4 na or more antihypertensive drugs. We conducted any investigations to identify potential secondary causes of hypertension, such as renal artery stenosis or hormonal imbalances.
Yes, we've performed extensive workup, including renal artery imaging, which came back normal. We've also ruled out secondary causes like primary aldosteronism and pheochromocytoma. The patient doesn't have any significant comorbidities either.
That case, we should consider optimizing the patient's lifestyle modifications. Have we thoroughly assessed their diet, physical activity, and stress levels? Sometimes, small changes in these areas can have a significant impact on blood pressure control.
That's a good point. I'll make sure to review those aspects with the patient. Additionally, considering the patient's resistant hypertension, we might need to explore more aggressive medication options. Have you come across any recent studies or new drugs that could be beneficial in such cases?
Yes, there have been recent developments in the field. We could consider adding a mineralocorticoid receptor antagonist, like spironolactone or eplerenone, to the patient's current regimen. These drugs have shown promising results in patients with resistant hypertension, especially when used in combination with other antihypertensive medications. Primary aldosteronism has been identified in up to 20% of patients with resistant hypertension, but only 20% to 50% of patients with primary aldosteronism present with hypokalemia.
That's an interesting suggestion. I'll review the patient's lab results to ensure they are suitable candidates for mineralocorticoid receptor antagonists.
Collaboration with specialists can definitely improve our patients' outcomes. In the meantime, let's ensure we provide adequate patient education and support to encourage adherence to their medication regimen and lifestyle modifications.
Absolutely. Patient engagement and education are vital. I'll schedule a follow-up appointment to discuss the proposed changes and address any concerns the patient may have.
Let's remain proactive in managing this case and continue to explore all available avenues. By working together and staying up to date with the latest research, we can provide the best care for our patient with resistant hypertension.
Agreed, Dr. Williams. Thank you for your insights and collaboration on this case. I appreciate your expertise and look forward to resolving this challenging situation for our patient's well-being.
You're welcome, Dr. Johnson. It's always a pleasure working with you. Let's keep the lines of communication open and continue to provide the highest standard of care.